Good afternoon, everyone, and welcome to this Penn LDI virtual seminar today. We are going to be focusing on examining trends and challenges related to consolidation in the healthcare industry. I'm David Grandy. I'm the Director of Policy at Penn's Leonard Davis Institute of Health Economics. So let's jump into our topic for today. While most Americans don't wake up thinking about how mergers and acquisitions in healthcare impact them, the trend toward greater consolidation does raise a lot of concern for consumers. Healthcare consolidation impacts every aspect of the healthcare system. It's not a new trend or a new challenge, but has rapidly accelerated in recent years. There were 1,887 hospital mergers announced between 1998 through the end of 2021, according to the American Hospital Association. But it's not just hospitals that we talk about with respect to thinking about consolidation. A December report from the Department of Health and Human Services found that the largest 10 skilled nursing facility chains, representing less than 2% of all chains, now own over 10% of all skilled nursing facilities. Primary care physicians' integration with health systems has increased dramatically from just under 20% in 2013 to nearly a third in 2017. And we see similar trends at even higher levels among specialists. As primary care serves as the first point of contact for many medical services, consolidation could have great impacts on healthcare markets and healthcare utilization. Now, consolidation could improve efficiency due to economies of scale and coordination across services. It can also give leverage to health systems over suppliers and labor. However, data shows consolidation and reduced competition generally leads to higher prices, and the research regarding quality of care is inconclusive. And what about health equity? There are some indications that consolidation will reduce access to healthcare for the most vulnerable populations through hospital closures and higher prices in highly consolidated markets. And adding to that pressure toward consolidation is the fact that private equity has entered the market as well. With all that in mind, in addition to predictions that the stresses of the COVID-19 pandemic will accelerate the pace of consolidation, we've invited 4 experts to help us unpack the complexities of consolidation in the healthcare industry. So let me go ahead and introduce them. First, we have Jim Capretta. Jim is a senior fellow and holds the Milton Friedman Chair at the American Enterprise Institute, where he studies healthcare, entitlement, and U.S. budget policy and global trends in aging, health, and retirement programs. Next up, we have Limor Daphne. Limor is the Bruce V. Rauner Professor of Business Administration at the Harvard Business School. Between 2012 and 2013, Daphne was Deputy Director for Healthcare and Antitrust in the Bureau of Economics at the Federal Trade Commission. Next up, we have Mark Seidman. Mark is the Assistant Director for the Mergers For division at the Bureau of Competition for the Federal Trade Commission. And lastly, we have Lois Utley, a healthcare policy analyst and advocate with 30 years experience helping communities protect access to needed care in the face of health industry consolidation. Most recently, she was Senior Advisor to Community Catalyst's Hospital Equity and Accountability Project. I want to welcome all of you and thank you again for joining this discussion today. So Limor, I want to start with a question toward you. The debate on healthcare consolidation and competition has been going on for many decades. The things we hear from health systems over and over again is that mergers can lead to efficiencies and better quality. Insurers and most researchers argue it simply leads to higher prices with no improvement in quality. So can you help us frame this conversation today on 2 fronts? First, when we talk about consolidation, we're talking about lots of different types of consolidation, horizontal, vertical. Can you help our audience understand the potential benefits and concerns with each? And then broadly speaking, what does the research tell us about mergers and the impact on cost and quality? So a tall order to kick things off, but thank you for doing that.
It's a pleasure. It's a pleasure to be here. And Professor is used to trying to pack in a lot in a short amount of time. So I'll be glad to try my best here. So I just wanted to start by clarifying for the audience that some of the terminology that I think you just used and that we'll be using throughout our panel, derives from the vertical chain of production, which would be the chain that goes from upstream inputs to intermediate outputs all the way down to sales and distribution. So in the case of, say, inpatient hospitals, which we'll probably be talking a lot about today, inputs might be physicians or, pharmaceuticals, medical devices. Then, outputs would be, say, inpatient services, and then there would be downstream referrals to post-acute care facilities. So when one speaks of a vertical merger, that would be up and down the value chain. So it could be integration of hospitals and physicians, say. And when one speaks of a horizontal merger, it's at the same level of production. So it would be suppliers that are providing the same service and in the same geographic area. So when I talk about the research, I'll reference what we know about horizontal and vertical. So the second part of your question was, what are the potential benefits and what are potential costs? And then last, I think, is what the research says. So in terms of benefits of integration, there are some that are common to both horizontal and vertical. And I should say there's also other stuff, other kinds of transactions that are not strictly horizontal or vertical, the chief one being, which we'll hopefully get to today, what I would call cross-market mergers. But there are non-horizontal mergers that are not strictly vertical. So the benefits of integration include economies of scale, economies of scope. For example, you might be able to staff 2 sites more efficiently than you can staff 1 site if you could share some of your resources. That would be a simple economy of scale. And another benefit might be the ability to segment your customers. You might, if you were a multi-hospital system, be able to develop efficiently a breast cancer center that would focus on care for a specific set of patients and be able to do so in a way that improves the quality of service that you're able to offer them. And that could theoretically be only realized through scale. So those are some benefits kind of on the input side, cheaper to produce, and on the output side, potentially higher quality, better access. There are costs too. And I would say that in addition to just organizational complexity and the costs of size, which can sometimes really offset some of those benefits, the one that I think we're going to be talking a lot about today is the risk that when parties merge, they eliminate the competition that formerly existed between or among them. And that competition could have led itself to constrained prices and improved quality. So to the extent that that rivals are merging, that is a real risk to the patient and to the payer. There are special, if you will, potential benefits of vertical integration that don't arise with horizontal integration. Given that I don't want to take over the entire start of the session, I'll probably set those aside. But I'll just mention one thing, because there is increasingly, we're seeing a lot of vertical and even what I just call generally non-horizontal, not 2 hospitals merging in the same area, but hospitals in adjacent areas or insurers acquiring physician practices. So all of these kinds of combinations. One potential benefit is aligning of incentives. And the canonical example of this is providers and insurers. So the insurer wants to keep claims down, and the provider wants to take care of patients and potentially has an incentive to bill a lot. If they are merged, then at least conceptually, they have the incentive to provide the best quality care or at least saleable care for an affordable premium. So that's an example of how being in the same financial organization, or at least potentially having common incentives, so this could be done contractually, vertically, can enable some benefits. So you asked about research. The research on horizontal integration is much more developed than the research on vertical or non-horizontal integration. I'll start with that. And the conclusions are pretty clear, which is across a range of healthcare subsectors, When rivals merge, prices increase, and there's scant evidence of improvements in the quality of care that patients receive. There's a little bit, but there is also a fair amount of evidence that quality of care decreases. So that's the conclusion on horizontal mergers. Vertical mergers or non-horizontal mergers. Let me talk about vertical. Almost all of this research has been hospitals merging with physicians. And the reason for that is that in order to conduct statistical analyses, you need to have a big sample. There are, every merger is a little different, but at least hospital physician acquisitions are sufficiently numerous that you can get a reasonable sample to study them. And you can use study designs where you're comparing affected areas and unaffected areas and patients whose physicians switch, ownership status, and that sort of thing. The research from that literature is pretty clear that vertical integration of physicians and hospitals is followed by increased spending on patients of vertically integrated physicians by higher prices negotiated for the physicians. And most recently, I'm seeing evidence for the hospitals as well, and mixed evidence on inequality effects. And then the last piece is about cross-market mergers, and I'll hold my comments on that, see if we get there.
Great. I appreciate you setting the stage because it is a complex landscape in terms of thinking about, I think when we talked about consolidation 10 years ago, mostly what people were talking about was horizontal and a little bit of vertical, but now even the nature of what vertical looks like has become way more complex in terms of thinking about the types of organizations that are coming together. So thank you for that, Limor. Mark, I want to turn to you, given what we just heard from Limor about the effects of consolidation, the differing effects from different types of consolidation. What is the FTC strategy to translate that information into enforcement strategy as you look at particular cases?
Yeah, thanks, David. And first, I need to give the standard caveat as a government enforcer. My comments today are my own and do not necessarily represent the views of the FTC or any individual commissioner. But yeah, Limor gave a great overview of the economic background for hospital merger enforcement. I think from my perspective, I think it's important to point out that the work that she and her colleagues have been doing fits into a much broader academic literature that I know Limor has been deeply involved in for a long time. But if you go back to the 1990s, the FTC and the Department of Justice really had a very hard time blocking hospital mergers, even the ones that were of direct competitors in really consolidated markets where, from an antitrust perspective, the market structure is just flashing red. Judges seemed really skeptical that hospitals would ever act anti-competitively, that they would ever raise prices or reduce services to their patients, especially with nonprofit hospitals. And so the FTC took a step back, and economists, including a lot of FTC economists, really studied the effect of hospital mergers on prices. And they were able to show empirically the effect that hospital mergers had, and that even nonprofit hospitals took advantage of the market power when they could. And so I think that history and that led to a resurgence in hospital merger enforcement. So I think that understanding that history is sort of where we've come from in merger enforcement is an important frame for how we think about the work that Limor and others are doing now. There is, I think, the effects of mergers between directly competing hospitals is now is pretty well understood. The details always matter. These are highly complex investigations and litigations, and each one is individualized. But I think it's important to point out that the mergers between directly competing hospitals, those are the ones that are right next door to each other in the same community, that are competing for the same sets of patients. Those are really the ones that create the most concern, and we've been very active on that front. Just in the last year, the FTC blocked 3 different mergers: one in Rhode Island, one in New Jersey, and one in Utah. And these were of hospitals really very much in the same area, and that came on the heels of a really important court challenge that Limor was involved in New Jersey in the Hackensack Meridian Englewood merger. So I'm hopeful that we're at a point now where hospital executives have gotten the message that merging with your significant competitor, your crosstown rival, is very likely to be illegal. And hopefully those mergers won't make it out of the boardroom anymore. Frankly, I don't think they should make it into the boardroom, but that would enable us as antitrust enforcement to focus on some of the other the other issues that that Limor raised in involving vertical mergers, cross-market mergers, the non-horizontal type of mergers, because as Limor was pointing out, the negative effects that we're seeing empirically and that the economic community is seeing empirically from those type of mergers seem significant. I think the real challenge and the thing that we're going to continue to work on, I think we'll come back to this point a few times today, but is translating what we're seeing, what Limor is observing in terms of the empirical economic analysis into enforcement, which means that we have to identify the mechanism, right? You can identify the outcome, but if we're going to go into court and stop a merger, we need to be able to explain to the court the mechanism. Why is this happening? And that's something I think there's a lot of really good thinking going on by Limor and by others on how that's happening. But I think it's important to remember that when you see a price increase or a quality decrease or a reduction in service, those are significant public policy problems that we all sit up and take notice of. But those are not themselves the violation of the antitrust laws. They are symptoms of the violation. The violation is the loss of competition. And so explaining the loss of competition in some of these other circumstances, it can be a little bit more of a challenge. But I think that we're making a lot of progress, and we're thinking very hard from the enforcement perspective. And I know that economists are thinking very hard about how to draw those connections, how to say what types of mergers are leading what types to what types of effects, and most importantly, as I mentioned, why? What is the mechanism for that?
Thanks, Mark. And we will come back to some of these issues because both of you have brought up, I think, really important trends as we're seeing more complex, mergers and acquisitions in healthcare. I do want to come back to the cross-market piece because I think that's not necessarily intuitive to a lot of people, the challenges that can pose. Before we do that, though, I want to invite Jim into the conversation. Jim, let's take a broader view of competition here. A lot of what we've talked about so far is about looking at the current state of the market. We see these, various entities trying to merge. The FTC can come in and try to, address that and try to stop certain levels of consolidation from happening. But a lot of markets are already pretty consolidated in terms of looking at where things stand today. So another question, of course, is how do we revive competition in markets, and how do we create opportunities for entry into markets so that even places that are already consolidated, we can try to turn back time a little bit and create some renewed competition.
All right, very good. Thank you. Thank you for inviting me to be part of this. I very much agree with the comments that have preceded my time here. So we're going to turn a little bit now to the thinking about it a little differently, but that doesn't mean I don't agree with the basic notion that strong enforcement of anti-consolidation policy is still very, very important to prevent further movement down the road we're already headed down. The question though that you just raised, which is a very good one, which is okay, but the horse is out of the barn in a lot of places. Are you going to break them up? That's not so easy to do politically and otherwise. And so what are the incentives to allow new entrants? How can any of that be encouraged at this point? And, when you look at healthcare, there's obviously a very large system of financial hurdles, barriers to entry to markets that new players would have to, jump over to get in. And it's not so easy, right? I mean, there's regulations associated with quality. You have to meet certain standards to be able to be certified as an inpatient facility. And there's a lot of expense associated with that and expertise. You have to be trained as a clinician, a physician, before you can, hang out a shingle and start taking care of patients. And how do you get through the process that allows you to do that. It's a fairly thin pipe through which those folks are coming into the market. And so if you're thinking about competition and pricing, on the supply side, you just have to go and take a hard look at everything both state and the federal government are doing to make it hard for new players to enter in. And just a couple of examples. Obviously, the most obvious one are certificate of need laws. I mean, there was a view along for many years, decades really, which was, we wanted to view inpatient care more or less as a public utility with regulated pricing. And, if we just had another hospital open up, we're just going to have more supply, supply will drive its own demand. And that was, I think, a very faulty view of how this system was going to play out over time. It still infuses a lot of policy at the state level where, frankly, there's a lot of politics blocking, changing that mentality about allowing new entrants into the market. So some of that needs to happen at the state level. Look at the clinician side, at the physician side. Essentially, there's a pipeline that is driven by funding through Medicare for graduate medical education, and through the states through its licensure system, and then through immigration law for physicians who would come into the country with training in medical schools elsewhere. And so all of those could be looked at to say, what do we need to do to change that to allow more supply, even on the clinician side, to come in, which, by the way, will have some material effect on some of these consolidation questions, vertical and horizontal, that are going on. And so if you want more pressure on pricing, even in the physician side, there's a number of dials that could be looked at to say, let's increase the supply of physicians. And if you increase the supply of physicians, it's very likely that there'll be less upward pricing pressure than there is today. I'd also look at things like, can you have more narrow purpose facilities allowed and licensed that can take some slices of the inpatient market away from some of the consolidated systems. Physician-owned hospitals was a very highly controversial item, but why not allow physicians to build their own facilities if it's going to directly compete, at least on some service levels, with an inpatient facility that's overcharging the paying customers? I would say also, the public payers, Medicare and Medicaid, they ought to be looking at how are they reimbursing the clinicians and facility side of their payment systems to allow new entrants into their markets. Are they doing anything maybe to encourage, through bundled payments, some shifting of control of the revenue streams away from the usual players? If you start to do that, you then provide opportunities for people to say, well, wait a second, I could get into that market and take some of that revenue and provide services independently of the existing incumbents. So all of this is to say that when you build a big, heavily regulated payment system driven through a lot of politics and regulatory policy, it does tend to, over time, favor incumbents. And they work the regulatory system, they work the political system, and that feeds into consolidation and lack of competition. And so on that side of the house, there are things that can be done to lower barriers to entry, allow more supply to come in a variety of ways, and try to open up some of these markets to more competition. I think I'll stop there. I put a lot of things on the table, and I'm happy to come back as the conversation continues.
Great. Thanks, Jim. And the questions are pouring in, so I appreciate that from the audience, and we will start to get to them. And I will consolidate some of the questions with the theme of the day. So Lois, let me turn to you. You think a lot about issues of access and equity and how that relates to these trends in the marketplace. Could you tell us some of the major access concerns that arise in the different types of mergers that we see in the healthcare market?
Sure. And thanks so much for giving me the opportunity to put the consumer and community voice into this conversation. The unfortunate reality is that more than 25 years of market-driven health facility consolidation has really left too many communities across the U.S. without timely access to needed care. Urban neighborhoods of color, residents of rural areas have suffered a lot as independent hospitals have closed or joined big health systems. The acquiring health systems in those cases are often portrayed, certainly by themselves, as white knights saving the community hospitals, but the actual impact is not always entirely positive. For example, acquiring systems, often move to close services like intensive care, labor and delivery, psychiatric care, cardiac surgery. And so the patients that used to get that care at their local hospital are then referred to these system hub hospitals where such services have been consolidated. And this forces people to travel out of their communities to unfamiliar hospitals and doctors. Certainly the hub and spoke model of health systems, may be good for the bottom line and can create centers of excellence in the delivery of certain types of care. But it poses really serious navigation issues for patients, especially those who are disabled, elderly, non-English speaking, without their own cars, can be really quite a problem. A couple of other points. When the acquiring system is a religiously sponsored one, then community hospitals are often forced to eliminate or restrict key reproductive health services, pregnancy emergency care, prohibit gender affirming care, and certain end-of-life options. And many people are not aware now that 5 of the 10 largest private health systems in the nation are operated by religiously sponsored health systems. 4 of them Catholic and 1 Seventh-day Adventist. And all these systems use doctrine to restrict care. And a final point, when the acquiring system is one of the private equity firms, now, increasingly active in the health sector, a community hospital may end up being stripped of its assets, loaded up with debt, and forced to lay off staff. So really leaving its patients with what amounts to just a shell of a hospital.
All right. Thank you, Lois. I want to come back to this issue that came up earlier, and then we'll move back through some of these issues again. But that issue that Limor and Mark brought up earlier about cross-market and what kinds of concerns that raises. And I think some of, even Lois, what you refer to as some of these large healthcare organizations that are religiously based are going across market as well. What kinds of, I guess first, what's the motive of health systems to start thinking about mergers across markets, and what unique concerns does that bring up? Why would competition be impacted by health systems going across markets? Limor, can I start with you on that one?
Sure, I'd be glad to discuss it. So in terms of the motives for hospitals to merge outside of the geographic area where they're rivals, where the FTC has been very active and very successful in challenging those kinds of transactions, we have these systems that are growing within states, across states throughout the country. In terms of stated motivations, they are the usual economies of scale. The bigger we get, we're going to be better. And a lot of these arguments are kind of vague. One of the specific ones I've heard is access to capital markets and the ability to have better bond ratings, credit ratings, and especially for some smaller hospitals, that can be a big savings for them, enable them to finance some improvements. Others are career concerns, the ability to kind of transfer employees, promote them if you have a bigger system. That's something I've heard. Rarely do the merging hospital chains talk about reducing employment, which would be on an ongoing basis, something that would save money, but is not a selling point, if you will, for these transactions. But what they don't say is that if you are part of a bigger system, then the data show that you end up with higher prices. And that is one of the big reasons for the payers and consumers to be concerned, which is, if empirically, and I could discuss the papers that show this, but they do show it, as the systems grow, they enjoy higher prices, commercial prices, where they can move those prices, and we end up paying more for that through our out-of-pocket spending and our premiums. Then what is the driver of that? And is it something that our enforcement agencies can challenge? They have not to date, with sort of one kind of settlement as an exception. They've not to date gone for trying to block such a transaction. And one of the reasons, not that I can speak for the agency's decisions, but one of the reasons that it is harder, it is a more difficult task for our enforcers to get at, is what are the drivers of those price increases? Mark made this very important point, which is there's lots of kind of potential harmful effects of consolidation. There are also potential beneficial effects, I should say. So I would say I'm opposed to anti-competitive consolidation, but not just consolidation wholesale by any stretch. He mentioned that the violation of the antitrust law pertains to a lessening of competition. Or potentially, engaging in exclusionary conduct that ultimately leads to less competition. So how is it, you asked this question, David, how is it that hospitals that are not competing for the same set of patients, when they merge, what kind of competition is being affected by that? And where I'll go with that is just to say that to the extent that an insurer is less willing to exclude a larger system than a smaller system, one that is spread out and is affecting multiple of its markets, then one can conceive of systems as kind of competing in a broader area than for patients, but actually competing to be included in networks of hospitals that insurers are forming in order to develop a broader span geographically of attractive networks. There are some reasons that kind of an argument can be difficult to make in court, but given the time frame, I won't get into those. But that is the crux of it, I believe. It's not that our enforcement agencies aren't aware that the mergers have subsequently led to price increases. I think that the challenge is identifying the right case to bring. And so if we have time at the end, I will advocate for regulation that actually tries to cap prices so that we can at least remove incentives to merge in order to raise prices, because it may take a while for enforcement to get in on this game.
Thanks, Leemore. There's a bunch of questions in the chat, and I'm just to indicate to all of you where I'm going. I do want to, Jim brought up some state laws. Lois, you brought up some unique concerns that are local in nature, and so I want to come into some of these certificate of need issues, as well as something, Mark, I want to ask you to comment on around certificates of public advantage. Some people have asked in the chat about nonprofit hospitals, and are there unique protections in any way that nonprofit hospitals have in looking at mergers and consolidation? So that's one thread. Another thread that I definitely want to get into a little bit is, all of the value-based payment, alternative payment models, and the push toward integration in our payment models. Like, can these things coexist with one another? Can independent providers survive in the healthcare market in terms of the payment models we're creating, or do the payment models themselves almost obligate independent provider organizations to join larger health systems? And then we'll, I got my eyes on the clock, and we will get to some other issues as well. But let's start with these some of these state laws and these unique issues. Maybe let's, Mark, have you first tackle certificates of public advantage. Could you explain what those are and how they're relevant to this conversation?
Sure, yeah, and I think it's worth noting that the FTC just completed a study of certificates of public advantage, or COPAs, as I'll call them. That's what they're typically called. So I think that's certainly worth looking up. It's available on the FTC website. But as a point of background, a COPA, a certificate of public advantage, is a mechanism that states use to approve mergers. It doesn't necessarily have to be hospital mergers, but in my experience, it's almost always used for hospital mergers. And typically, states will implement a COPA law. There's kind of two steps to it. The state legislature has to pass a COPA law, and then it's in the case of hospitals, it's often the Department of Health that will actually evaluate a merger and grant the certificate to a set of merging hospitals. The states often implement these laws at the behest of hospitals that are thinking about a merger that they reasonably might think would run afoul of the antitrust laws. And the COPA, the state COPA law, can create a shield against federal antitrust enforcement based on a doctrine from the Supreme Court called the state action doctrine. We can go way down that rabbit hole, but in the interest of time, I'll just say that's the question of whether or not a COPA actually creates that shield is a pretty fact-specific question. But setting that legal question aside, I think in looking at it from more of a policy perspective, COPAs might not necessarily be a common occurrence if you're looking at all hospital mergers. But I think it's fair to say if you're thinking about the anti-competitive hospital mergers, in comparison to the ones that we've been challenging under the antitrust laws, they've become a fairly frequent tool for hospitals and for states to use. And the FTC study showed that a lot of the harms that we've predicted in individual instances, and oftentimes the FTC has submitted public comments or testified at hearings about the risks of these types of consolidations, and that they could create higher prices, reduced access, reduced quality of care. That those things have in fact come to pass. So I think it creates an important public policy question for states, and I think that we've taken pretty consistent positions. We certainly look at each COPA application and merger individually, and when we comment, it's individual based on those mergers. But I think there's a couple broad statements that I can make based on my experience looking at COPAs and testifying in some cases about them. I think states often have a false sense of their ability to regulate the benefits of competition. If they're going to sacrifice competition, typically the idea of a COPA is, well, we can replace those benefits with regulation. Controlling hospital prices is hard enough. Hospital pricing is incredibly complex, and controlling that through regulation is hard. But I think even harder than that is mandating access, mandating high quality care, and even further than that, I have no idea how through regulation you mandate innovation. I think that's really a reach, to say the least. And I think that's because regulation, while it has a really important role to play in healthcare markets, I'm not suggesting that there's no role for regulation. It's a partner with antitrust enforcement. But if you view regulation as a substitute for competition, that's a really difficult place to be in. And I think the other big question that states need to consider is the length of this effect, right? If you as a state are going to grant a COPA to a merger that would otherwise be illegal under the antitrust laws and be anti-competitive, you're likely going to be living with that market structure for a long, long time. An important example of that, there's a number of COPAs around the country, but I think an important example is the Mission Health COPA in Asheville, North Carolina. This was a COPA that was granted in the middle 90s, around 1995. And after about 20 years of the COPA being in place, Mission Health successfully lobbied the North Carolina state legislature to repeal the COPA. And so after 20 years, the same market structure was in place. And I think there's serious questions, and this comes up in the FTC study, that COPA was not that successful in controlling costs. But after 20 years, you don't even have the fig leaf of regulation to control that hospital system. And subsequently, Mission Health sold to the for-profit system, the Healthcare Hospital Corporation of America. And so, it's query whether, had you told the residents of Asheville in 1995, when that community's thinking about allowing the merger that created the Mission Health System, look, in 20, 25 years, you're going to be looking at HCA owning the major hospital here with no COPA. That's something that really should give states pause in thinking about going down this road.
Let me bring up this. Limor, did you want to jump in? Okay. The other state law that Jim brought up is certificate of need laws. Lois, you have experience working in New York State. New York State has a health equity assessment law that actually relies on certificate of need. I think we can look at certificate of need both for entry as well as exit in markets as well. And so are there ways that you've thought about certificate of need being leveraged to address merger concerns more broadly?
Yes, definitely. New York is one of, I think, 35 states plus the District of Columbia that has a certificate of need program. Nonetheless, we've seen a loss of more than 40 hospitals around the state over the last 20 years. And we've seen these big systems gobbling up hospitals and closing some, essentially abandoning some of the urban communities of color in rural areas. Well, the New York Health Equity Assessment Act was introduced in the state legislature in 2021 in response to what were really stark inequities in access to hospital care that had been revealed by the COVID-19 pandemic. It was passed by both houses of the state legislature, signed into law by Governor Hochul in December of 2021. It's going to go into effect in June of this year, and we are now engaged in an extensive period of rulemaking to implement the law. But here's what it would do. Anytime a proposed health facility transaction would result in a substantial reduction or elimination of services, then an independent health equity assessment would be required. And the purpose really is to identify what's going to be the likely impact on medically underserved people. And the law defines medically underserved in a very inclusive way, to include racial and ethnic minority groups, uninsured people, women, LGBTQ plus people, immigrants, people with disabilities, older adults, and residents of rural areas. So when submitting its certificate of need application to make the change, a hospital will be required to hire an expert independent entity to carry out this health equity assessment. And the assessor would have to have some credentials, right, in areas like health equity, anti-racism, community engagement. They would need to certify that there's no conflict of interest or bias towards the hospital, such as being an ongoing consultant to the hospital. The assessor would be required to carry out meaningful engagement, an important term, of the affected community members and stakeholders like hospital employees, county health department, et cetera. So let's take an example. If a merger was going to cause the maternity unit to close at one of the hospitals, the health equity assessment then would focus on the impact on pregnant people. It would identify alternative places these people could go for maternity care, how far away they are, whether they can be reached through public transportation, and so on. The assessment would look to identify any potential ways to mitigate these likely impacts, like providing transportation, for example. The health equity assessment would be filed with the Department of Health, and it would become an important part of the information that the department can use in deciding whether or not to approve the CON application. For example, they could attach a condition to it to address some of the negative effects. This new process represents just an extremely important step forward in ensuring that affected communities will be notified and given a say when their local hospitals or other health facilities are proposing big changes in the services on which the community has relied.
Thank you, Lois. So let me shift to the other issue that I think has certainly come up in the chat, is the move toward alternative payment models. Value-based payment has been a big trend and big push, supported by federal policy, out of CMS, being pushed by private payers as well. And the question is, are those alternative payment models really driving a need on the provider side, a survival need to join larger organizations and consolidate? Or can those payment models coexist with, Jim, to some extent, what you talked about earlier, which is the ability to preserve independent providers that are not part of large incumbent organizations? I know that's a hard question to answer. It's in some ways, I realize, unanswerable, but I want to see if any of you want to take a crack at that one.
Well, I'll jump in here and give it a shot. Like everything in health policy, it's a complicated situation, right? So the motivation for alternative payment is to help the provider community get incentives lined up toward efficiency, toward saying, here's how we're going to pay for a set of services that maybe is not individualized, but more bundled up. Maybe it's the total cost of care for a whole population. And if you work together across the provider community, you might be able to find efficiencies and other ways of changing the care process to make it more efficient. You save money, we save money. So that's sort of the theory of it. But of course, to be able to participate in such a thing, that hurdle I talked about at the beginning, the cost of entry into this thing is kind of high. You got to be able to track the patients, accept risk. You got to have enough of a population so that if a few expensive patients come in, you're not really out of a lot of money. So the size of the system can have a material effect on your ability to absorb this kind of payment model. So yeah, I think there were incentives built into this that might incentivize bigger systems over smaller systems. Now, having said all that, I think that this whole initiative is sputtering a bit, and people are trying to figure out, well, where does this go exactly? And I think there's an opportunity here to maybe do more alternative payment models that are more micro and manageable at the physician practice level, and not so big so that everybody's driven toward major systems. So some rethinking of this is going on. And let me also just say one other thing is I think financial incentives are really key to all of this, is that it's going to be very difficult, as Mark said, to regulate the outcome you want. It is very difficult. You can do things to constrain, cap, prevent, but you can never make a hospital come into a market and start serving patients. You can't create a hospital through a public policy. You can't just sort of say, we're going to make you do this. So you have to have the right financial incentives to allow systems to want to participate and compete and potentially, get good returns for their own system. So I think the idea of how to think about this really needs to be an incentive-based way of thinking about it. And you want more entry, more participation, more players, more supply across the board. That, I think, is probably our best way forward.
Well, the term. Oh, go ahead, Mark.
I was just gonna add a little bit to what Jim said, and I think there's this is a broad health policy question that goes well beyond just antitrust, which is my small sandbox here. But I think it's first of all important to remember that nothing in the Accountable Care Act or any of the other regulations or laws that we're talking about displace the antitrust laws. They didn't repeal them, and none of them even suggest that the role of competition is any less. And I think as you think about how these payment systems develop, the role of competition can be really important, right? If you are having rival hospital systems in a given area, all thinking about different ways of taking on risk and different ways of managing risk and working with a competitive insurance market where the insurers are also thinking about how to share that risk with providers, that's a place where that allows for and incentivizes some innovation. If you start allowing consolidation, or you start seeing consolidation in those areas, maybe those incentives to innovate, the pressure to innovate, can be lessened. And I think there's a legitimate concern that, especially from the healthcare provider side, the old fee-for-service system, it can be favorable. If you don't have competitive pressure to move beyond that, maybe you hold on to that a little bit longer. So I think it's important to think about both the regulatory perspective and the health policy perspective of where do we want to go, but also think about the competitive part of this and how do we maintain the incentives for market participants in the healthcare industry to do some of the innovation beyond just the policymakers.
So, Limor, you brought up earlier that you hope we have time to get to the question of regulated prices. So that's sort of the elephant in the room, which is, all of this conversation is based around trying to find ways to maintain competition in markets. There's an alternative view, or some may say complementary, some may say not, that would look at regulating prices as an alternative approach to address this problem. I want to give you a chance to weigh in on that since I know you brought it up earlier.
I appreciate that very much. I think just as we need innovation from our businesses and want to have an environment that promotes that, we need innovation from our governments. And what's great is we've got the states and there are laboratories for this, and they are experimenting. So as I mentioned earlier, one possibility is that states can cap certain prices and then kind of take the wind out of the sails of those who might merge in order to raise prices, at least up to that cap. I would say these regulations, and that's not the only one, can coexist. And ideally, my ideal would not be kind of fixing prices for everything and everyone, but would be something like maybe capping out of network prices, which can constrain the negotiated in-network price, as we've seen in the Medicare market, right? Where if you don't come to an agreement with Medicare Advantage plan, then you get paid Medicare fee for service. And so the rates that Medicare Advantage pays are not too different from what Medicare fee for service pays. Even in a highly concentrated industry like kidney dialysis, where the rates are 3-4 times for the commercial sector what they are for Medicare Advantage, the estimates are about 130% of Medicare rates. So suggests that outside option can really constrain things without getting into the business of setting all the prices for everyone. So the idea is that states can either, semi-globally try to regulate some portion of prices. They can do it through insurance rate review, or they can, and a number have attempted to influence the incentive to charge higher prices through their plans for state employees. So there are states that cap the amounts that they will pay on behalf of state employees, which does put pressure on the systems to start figuring out how to be viable under lower rates.
All right, thank you. Looking at the clock, we don't have a lot of time left, so I do want to give a chance for one final word from everyone. And I guess the overarching question here is that, as has been evident in this conversation today, consolidation is a growing problem, but a very hard problem to solve. So thinking about if you were in the shoes of that of policymakers, I know, Mark, you are somewhat in those shoes, what would your recommendation be if you had one recommendation for what policymakers could do? And Mark, I'll give you some latitude here. If there's something that you feel like the FTC needs more than anything else for effective enforcement, what might that be? So maybe I'll ask Lois, do you want to take a swing at this one first?
Okay, yeah, sure. Happy to take a swing. I know that health planning is not everybody's cup of tea, and there's been a lot of opponents to it over the years. We got rid of the health systems agencies a while back, but really it is a big problem that there is no regional or statewide health planning in many states, including in New York. So when a certificate of need comes in to the health department to open a new this or that or merge it, there's nothing to compare it to. What we need is a plan that says, look, these communities already have an oversupply of hospital beds, the Upper East Side in Manhattan, for example. These other places have gaps in care, parts of Queens where like 4 safety net hospitals closed and left Elmhurst Hospital, a public hospital, trying to deal with the COVID pandemic. So if we had a plan, then, picking up on Jim's idea about incentives, maybe we could incentivize hospitals and health systems to open places in the gap areas instead of in the places that already have too many hospital beds or are, frankly, more attractive because they're white suburbs with middle income people with commercial health insurance. We need some incentives there. We need regional planning. And we also need to look at Medicaid reimbursement rates for things like maternity care, which are so low that, you can understand why hospitals look at maternity care as a loss when it should be one of the most important services that a hospital can provide to its community.
All right, Jim, what's your one wish? Maybe I'll give you 30 seconds because I'm getting nervous looking at the clock.
You should be. We're almost out of time. It's sort of an idea that Congress working with CMS really ought to have, again, an incentive system for new entrants into overly consolidated markets. Some lowering of the regulatory hurdles, maybe something that sort of says, reimbursement will reflect that you need 3 or 4 years to get up and running, but something to allow across the board new entrants into markets to get a foothold and start competing against the incumbents.
Mark?
Yeah, I'll try to be brief. I think two quick things come to mind. I mean, one is a little bit of what we mentioned before: a continued engagement among the law enforcement group community that I'm a part of, the economic community that Lemore's a part of, and the health policy community that Jim and Lois are a part of, to try to understand the mechanisms beyond the head-to-head competitor type of mergers that have been the bread and butter of our hospital merger enforcement, but to really think beyond that and think about what are the mechanisms, what's driving this, and how can we translate that into enforcement? How can we fill in those stories with specific evidence around a specific merger that can lead a court to stop mergers that are causing consumer harm, that are causing harm to healthcare labor forces, that are causing harm to communities. I think the other thing that I have to say is that this is incredibly intensive work from our staff works incredibly hard to look at these mergers, and the amount of resources that were allocated by Congress has a direct effect on the amount of work we're able to do and the number of mergers we're able to look at, and the number of mergers we're able to litigate, because that is, when we go to court, it's an incredibly expensive and intensive process, to say the least.
All right. Thanks, Mark. Lemore.
I had some time before to talk about payment reform. So you said a wish. In addition to bigger budgets for our antitrust enforcers, a wish is some insurance market reform that involves individuals making choices over their plans with income-based subsidies and using our preferences to influence the market, and and then that way place pressure on some of the incentives to consolidate to increase price without improving quality.
All right. Well, I want to thank the 4 of you for this really rich discussion. I know that it's a rich discussion because the chat was just lighting up with questions coming in. I know we weren't able to get to all of them. This is an incredibly complicated issue. It's, it truly is an onion that you keep peeling back and finding more issues and challenges to try to think through. But it is a major source of price inflation in healthcare, also alongside, of course, a big trend in healthcare today. And so trying to find some solutions is incredibly important from a public perspective. So again, thank you to the four of you. I just want to mention to our audience, please save the date and join us on February 10th for our next seminar on how to optimize the opioid settlements, which is another critical issue facing state and local governments as they figure out the best ways to optimize the allocations of those funds. So thank you again, and best wishes to our audience. Thank you very much.